Good afternoon. On behalf of the Agency for Healthcare Research and Quality, I'd like to welcome you to our web event entitled Payment Models That Support Medical Homes and Accountable Care Organizational Principles, Maryland's Experience. I'm Judy Consalvo, and I'm with AHRQ's Center for Outcomes and Evidence. We're very excited about today's topic and glad to see that you share our enthusiasm. We have over 800 registered for this event today. Next slide, please. Before we begin, I would like to introduce you to our webcast console. The console can be resized to fit your entire browser window. All the components on the console can be resized, moved, and minimized into the menu dock at the bottom of the console. If the slides are too small, click on the lower right-hand corner of the slide window and drag your mouse down to make it larger. Twitter functionality is available in the console for today's webcast. Feel free to participate using the hashtag AHRQIX. We are pleased to offer closed captioning on this web seminar. To access the closed captioning, please click on the link called Closed Captioning that is on the lower right-hand side of your screen view. After you click the link, a new window will display the captioning. I would also like to remind you that if you experience any technical problems, you may click on the question mark button at the bottom of the screen to access the help guide, or click on the Q&A button at the bottom of your screen to contact us with your question. Our technical staff will work with you to resolve any issues. The last 10 to 15 minutes of this web seminar is reserved for a discussion based on questions that you submit. Questions may be submitted at any time during the presentation. Simply click on the Q&A button at the bottom of your screen, then type your question into the Q&A box and select Submit. We welcome your questions and comments on the upcoming presentation and look forward to an engaging dialogue that will promote the spread of healthcare innovations. Next slide, please. Today's slides are available by clicking on the widget at the bottom of your screen that says Download Slides. This will generate a PDF, a version of the presentation that you can download and save as desired. Next slide, please. The presenters that you will hear from today are innovators from AHRQ's Healthcare Innovations Exchange. For those of you who are new to the Innovations Exchange, I'll take just a minute to give you an overview. AHRQ created the Exchange to speed the implementation of new and better ways of delivering healthcare. It offers busy health professionals and researchers a variety of opportunities to share, learn about, and ultimately adopt evidence-based innovations and tools suitable for a range of healthcare settings and populations. The Exchange website includes a searchable database of quality tools and service delivery innovations, as well as policy innovations, such as the ones that you will hear about today. The Exchange also contains both successes and attempts, innovators' stories and lessons learned, and expert commentaries. To assist you in implementing these innovations, AHRQ also supports learning and networking opportunities such as web seminars, tweet chats, and podcasts. We post new content to the website every 2 weeks on a range of topics and hope that you will sign up to stay connected with us if you have not already done so. Next slide, please. We have a number of upcoming web events to share innovation health strategies and promote the spread of innovations. Our next learning and networking event is our upcoming web event on May 9th from 1 to 2 p.m. Eastern Time called A Close Look at Care Coordination, West Virginia and Arkansas's Experience. To register for this event or receive more information, please visit our website at www.innovations.arq.gov. The website also holds an archive of our past web events, podcasts, and tweet chats, and we also invite you to take a look and download materials that may be useful to you in your practice. Next slide, please. So let's turn to our agenda for today. It is my pleasure to introduce our moderator, Dr. Meredith Rosenthal. Dr. Rosenthal is Professor of Health Economics and Policy in the Department of Health Policy and Management at the Harvard School of Public Health. Her research examines the design and impact of market-based health policy mechanisms, with a particular focus on the use of financial incentives to alter consumer and provider behavior. Meredith?
Thank you, Judy. I'm pleased to be moderating this web seminar to help promote the spread of health policy innovations. I'm going to start us off by providing some context for today's presenters. It hardly needs to be said what the motivation bringing us here together is, but clearly underlying concerns about the affordability of healthcare and uneven quality are at the heart of what we're talking about today. And when we look at these problems, as complex as they are, a common theme running throughout is the fragmented healthcare delivery system. In particular, no individual provider has the right set of tools and incentives to worry about the whole of healthcare and think holistically about managing patients for the best outcomes at the lowest cost. So the accountability contracting issues we're going to talk about today are a way of using performance measurement and incentives to assign accountability for a population to a provider or a set of providers. And for the most part, we'll hear today about patient-centered medical home initiatives, a primary care-based accountability model. But we'll also think of these as building blocks and take the discussion towards accountable care organizations, which may include a range of other providers. So just to get us on the same page about patient-centered medical homes, you'd have to be living under a rock to have not heard a lot about these over the last number of years. Of course, this concept has been around for decades, but for a little more than 5 years, patient-centered medical homes have been looked at as a potential source of solution to the healthcare fragmentation problem and really as a contracting vehicle for improving healthcare delivery. The joint principles issued in 2007 by a group of specialty societies really are the common thinking around the higher level concept of the patient-centered medical home that many of these initiatives are working towards. And the National Committee for Quality Assurance has come up with a measurement tool that allows payers and others to recognize patient-centered medical homes based on objective and concrete structures and processes. So largely what we're talking about here is a primary care-based model that allows for proactive, accessible care focused on individual patient needs, and again provides a way of thinking about a new payment model that would allow those medical homes to treat patients more flexibly, more holistically, and not just through office visits. So patient-centered medical homes have really taken off in the last number of years. Today we're going to hear about a couple of state-based initiatives, of which there are many. As well, the federal government has gotten into patient-centered medical home pilots and other activities through the Centers for Medicare and Medicaid Services. There are several Medicare demonstrations and efforts that Medicaid, in partnership with the federal government, has undertaken in a number of places. These initiatives vary in their emphasis and their focus on pediatric or adult populations, but they are all intended to improve the quality of care and to address affordability concerns, and in many instances improve access for underserved populations. So here today we're going to talk about payment incentives around medical homes. One aspect of how policymakers may support medical homes is to think about a payment model that's more in keeping with what medical homes are attempting to achieve. And in particular, the payment model that's been favored here is a mixed payment arrangement. Given the problems with fee-for-service and its focus on very narrowly defined billable services, there's an appeal to using essentially a capitation fee, a case management fee that's a lump sum paid to the practice that gives the practice the flexibility to use those funds for non-visit-based care, non-traditional care, to use those funds to allow providers to care for patients in their absence, as it were, for example, by looking at registries, doing outreach. In addition to this mixed payment approach that de-emphasizes fee-for-service, many payers also include pay-for-performance that target both quality measures, particularly chronic disease management measures, and also target specific measures of downstream cost, including the cost of hospitalizations, emergency department visits, and similar types of costs. There are a number of challenges to contracting with medical homes. Many of them relate to the fact that most primary care practices are quite small and their patient panels may be quite small. It also can be challenging for payers to operate in this multi-payer environment when all payers may not be entertaining the same kinds of contracting approaches, and this makes it hard for a practice to fundamentally change what it's doing. It makes it hard for payers to avoid spillover effects and to really get the attention of individual practices. And so you'll hear about some multi-payer efforts. Thinking back about the small practice problem, this can be challenging not only for setting up all of these contracts, but because there's so much potential for random variation in many of the measures we'd like the practices to be accountable for, including, for example, preventable hospitalizations, which may simply be infrequent enough events that a small practice can't be reliably measured on them. And then finally, with all kinds of high-powered performance incentives, payers need to consider potential unintended consequences, including the lack of accessibility of practices to certain kinds of high-risk patients that might come with performance incentives, or concerns simply about the financial stability of practices. And that will lead us to talk about thinking about ways to channel some risk to accountable practices, but guard against some of the most serious kinds of fluctuations. So as I mentioned, I think in the discussion today, while we'll focus on the experience with patient-centered medical homes, we'll want to talk about moving out from primary care. Almost surely, primary care-based accountability alone without requiring changes in accountability for specialists and hospitals will not be the formula for the long-term success of these initiatives. And so we should talk about how do we build shared accountability across unrelated specialty and hospital practices alongside primary care practices, or think about using these higher-level integrated systems as accountable care organizations. There may be any number of intermediate steps. I think there's some good examples in Michigan, Blue Cross Blue Shield, for example, rather than looking for accountable care organizations alone, has begun to give downstream providers, specialists, and others incentives to work more closely with their patient-centered medical homes, something that we've heard from medical homes they are seeking, partners in the field. So just to give you an example, I wanted to illustrate here the notion that even when we think about these large integrated systems acting as accountable care organizations, we can think about a range of risk-sharing arrangements. Accountable care contracting arrangements don't have to be global hard capitation, as we used to call it, but they could involve something like a risk corridor. Here's an illustration of an early version of the Medicare Shared Savings Program. And on the x-axis, you have the total spending for the population. On the y-axis, you have the shared savings, either bonus or penalty. And so you can see there's a corridor in which those bonuses and penalties initially shrink as spending goes up and then ultimately go negative, but it's capped. And so those flat lines at the top and the bottom indicate this essentially risk protection for the ACO arrangement. So we can talk about how much sharing we want to do with accountable care organizations, whether there's a threshold for minimum savings, and all of these contracting issues that need to be worked out in practice. And we'll hear from Ben and Craig about how those have worked in their states. So before I pass it off, I just want to note that as we start thinking about getting more integrated healthcare delivery, we're going to need to have some flexible payment concepts around very different kinds of delivery models in different contexts. And so while many payers and policymakers are working on trying to think about what the right delivery model is it an integrated system? Is it a network? And that will likely vary by state and by population. Likewise, the payment arrangements that complement those delivery organizations need to be crafted in ways that appropriately handle trade-offs in risk, protection for high-risk patients, but also do effectively align accountability, as is the goal of these initiatives. So it is now my pleasure to introduce Ben Steffen, who is the Executive Director of the Maryland Healthcare Commission. Both in this role and in his previous roles, Ben has been highly involved in many of the innovations that Maryland has put in place to improve access to healthcare and healthcare quality in Maryland. Maryland is currently one of 5 states involved in the Centers for Medicare and Medicaid state innovation models. Ben will share Maryland's experience with the multi-payer program and more. Ben?
Thank you, Meredith, and thank you, AHRQ, and your consultants from Westat for putting this on. Before I begin on our PCMH program, I'm going to give you a very brief background on Maryland. If you're not familiar, we have quite a few very small primary care practices in the state of Maryland, and it is often the case where there is a misalignment between carriers and practices. Reimbursement has been an ongoing challenge here in the state, both in the primary care and specialty care setting. The state had looked at reimbursement for a number of years of practitioners, and as a result of work done in 2009, we had concluded that simply requiring higher payment for primary care would not be adequate for solving the challenges here. Fortunately, work already being done elsewhere suggested that we could try a pilot with an advanced primary care initiative to test some of the ideas we had going forward. Key to those ideas were the concept of a multi-payer initiative. As many of you know, Maryland is the only all-payer hospital rate-setting state, and this concept is popular here, and we thought we'd take that into the dimension of primary care. The state decided in 2010 that the best approach was through legislation that solved several problems. It allowed us to convene payers together and talk about reimbursement. Without a action by the state, it is likely that payers would collide with Sherman antitrust law if they met together to discuss a reimbursement. We also had to solve several specific provisions in Maryland law that limited our approach to the PCMH program. Specifically, there was a prohibition against cost-based incentive programs in the state. That is, practices could not be rewarded for simply reducing spending through an incentive program. And secondly, we also had some very strict limitations on data sharing between carriers back to practices in the state that also would by themselves serve as impediments to the program. We also had as a goal, while we wanted to launch a multi-payer program, we also wanted to have the flexibility for carriers to launch their own programs as well. So to overcome the antitrust provisions, the legislation designated a state agency, the Maryland Healthcare Commission, to convene payers to exercise what's called the state action exemption under federal state antitrust law. Over a period of several months, we developed standards and processes for both the multi-payer program and for the single-payer programs, which have also gone ahead in parallel with our multi-payer program in the state. We have 2 single-payer programs. I'll talk briefly about that later in my presentation. Our multi-payer program includes 5 large commercial carriers and the 6 Medicaid managed care organizations that serve our Medicaid program here in Maryland. So a very brief overview of the program. This is a pilot, so practices actually applied. Approximately 200 practices sought to participate. We selected 52 practices with characteristics that largely mirrored the overall practice population here in Maryland. We have 7 solo physician practices, 1 nurse practitioner-led program, and then the rest of the practices are made up of from small to medium to large practices by our definition of large here in Maryland. Among that group is 2 federally qualified healthcare FQHCs. FQHCs presented some particular problems for us as they are cost-based under the Medicaid program, and we had to fit in our new shared savings algorithm under that arrangement as well. Altogether, 330 providers are included in the program. They include both physicians and nurse practitioners. I think Maryland was one of the first states to actively reach out to nurse practitioners and seek to engage them in the program. And everyone is bound together, both providers and payers, through a participation agreement that spells out the various organizations' responsibilities under the program. The structure of the program is state-led, but payer and provider organizations have significant input into the operation. The 3 key elements of the program are practice transformation, led by a collaborative of Maryland physicians from the University of Maryland School of Medicine, Family Medicine Department, as well as Johns Hopkins community physicians, as well as leading-edge practices that had already achieved NCQA Level 3 recognition in the state before the program began. Their roles are leading the organizational change, assisting practices in achieving NCQA recognition, assisting in the redefinition of roles within a practice, defining the role of a care manager, which is specifically spelled out in our participation agreement, and broadening and reaching out to the community for practices in how they engage with services in their particular localities. The payment model, Dr. Rosenthal talked a bit about that. We have a hybrid model. It includes a upfront investment payment as well as a back-end shared savings arrangement. Importantly, the shared savings arrangement is based on the assumption that there would be a recoupment of the investment payments before any shared savings would be distributed. And lastly, as it's a pilot, we wanted to learn more even as we went forward, and we had specific requirements, and we have a formal evaluation underway. The legislation, interestingly, specified some of the considerations we were to examine as part of that evaluation, in particular, the impact on both patient and provider satisfaction here in the state, and the ability of the PCMH model to reduce health disparities. So briefly, what have we accomplished in the multi-payer program? Approximately 250,000 folks are engaged. They're the privately insured and Medicaid patients. And when we say engaged, we mean that those patients have a paying payer behind them. That is, the practices receive a fixed upfront payment as part of the initiative. There are, of course, within those practices, other patients who receive the benefits of a PCMH practice but have no payer incentive payments as part of that access. We've moved all 52 practices through NCQA recognition, with 2/3 of them already at Level 2 or Level 3 already. And we've also worked with practices, and they have successfully reported quality information from their EHRs for both calendar year 2011 and 2012. We spent a significant amount of time aligning the 24-odd quality measures that we used under our programs with other initiatives that were underway in the state, particularly the National Coordinator ONC's Meaningful Use Measures. And as part of this presentation today, we did crosswalk our measures with those specified under CMS's ACO initiatives. There are 8 measures that are collected, required by CMS as part of ACO requirements. When we actually crosswalk our multi-payer measures with the ACO measures and with the private carrier measures that are used in the state, we find, unfortunately, however, there are only 2 measures that are used consistently across all programs. We have some work to do here. The major focus of my remaining time will be on the payment model. As I mentioned, it's a hybrid model. It still remains anchored in fee-for-service payments, and it's important to note that the fee-for-service payments are different across the various carriers. That remains so. Medicaid MCOs have different payment levels from the private carriers, and each of the private carriers varies somewhat. Those did not change. What we did, however, was harmonize what we call the fixed transformation payments, the upfront payments that go to practices for hiring care coordinators, for adopting certain non-face-to-face visit activities that are thought to benefit care. The payment levels were spelled out in the participation agreement and did not differ by the complexity of a patient. They differed, however, by the level of NCQA recognition that a practice had achieved. And as a practice moved through from 1 to 2 to 3 in terms of NCQA recognition, in consideration of the fact that as a result of meeting the higher levels of recognition, you could do more, they also received higher fixed transformation payments. At the conclusion of each year, we construct a shared savings calculation. Practices are benchmarked against a historical or baseline total cost of care measure, and if they are able to demonstrate that the total cost of care for patients attributed in both years is lower, they would share in that savings. In order to be eligible for shared savings, the practices are required to first of all report on the clinical quality measures and to meet our utilization measures. In the first year, the quality measures only are reported. In the third year, we will be setting benchmark thresholds for performance on those clinical measures. A bit more about shared savings. We define total cost of care to include all services. Of course, those who are familiar with both the PCMH and the ACO models, when we talk about total cost of care, we're including services provided within and beyond the primary care setting. In Maryland, we elected to have a somewhat bifurcated approach. For the private carriers, we elected not to include pharmacy because we had some self-insured participants who had carved out the pharmacy benefits. And for simply a complexity issue with patient IDs, we elected on the private side not to include pharmacy. On the Medicaid side, we are including pharmacy. We've recently learned that TRICARE is participating, and they too will be including pharmacy in their shared savings initiative. We set a benchmark against which practices were compared. It was for each practice its own total cost of care for patients in the program in the baseline year. That was then inflated forward to account for overall cost growth in the state. 7.4% was the figure we had for 2010 to 11, which was a pretty significant growth in cost, I think I would note, compared to some of the figures we've seen nationally, which may account for some of the shared savings we got initially. So if practices were able to demonstrate that their costs were below the budget, then they participated in shared savings. The practices earned from 30 to 50% of those savings, depending on the number of quality metrics they reported in the first and in the second year. By the third year, they will be not only held accountable for reporting on those metrics from their EHRs, but also for meeting the quality thresholds that we set in the program. For those who are interested in a few more details on the shared savings program, I already noted that in order to be considered, a patient had to be attributed in both the baseline and the comparison year. We also adjusted the calculations to exclude certain high-cost patients, those who had died, the cost of trauma care, or patients that had suffered traumatic injury were also excluded, and we capped the patient cost at $75,000 in both the base year and the comparison year. We looked at more sophisticated statistical approaches, a trim at the second standard deviation or the 95th percentile, and we actually elected to use a dollar figure because it was easier to understand. I'll note here the third point, that we used our own all-payer claim database to both attribute patients and to conduct the shared savings calculations. We are one of only a few states that are using all-payer claim data to actually distribute payments. And I can tell you that once you move from simply counting, for example, colonoscopies to looking at how reimbursement might be distributed, everyone pays a lot more attention to what's in that APCD. Measures and how we looked, how we completed the shared savings, moving from top to bottom. Practices first had to demonstrate they could report quality measures. If they did that, and you can see that 49 of the 50 organizations reported quality metrics in the first year. Moving then to the second column, of those 49, 23 did generate some shared savings. It wasn't significant, but we were surprised even in the first year that savings were produced. And then in the bottom row, you can see that 23 were eligible for some shared savings. Surprisingly, perhaps not surprisingly to others, only one of those practices was among our pediatric subset, and we're one of the few states, I think, that does include pediatricians in the initiatives. So a quick question on why did practices generate savings? They first of all had to prove they could submit quality data. We saw, and these were simply very simple bivariate correlations, a moderate relationship between reduced hospital days and lower total cost of care, about a 0.3 correlation, a weaker relationship between ED visits and lower cost, and then we simply didn't have enough cases to look at whether there was a relationship between reduced readmissions. And as Dr. Rosenthal observed, some of these measures are very difficult with small practices, as we faced. We also observed that random variation in our small practices drove some of the savings, and applying the same principle that's used in the ACO model, we elected to trim savings rewards, or top them off at 10%. That is, a 10% practices could make no more than a 10% improvement for purposes of shared savings. If they reduced costs by 12%, it was cut back to 10% because we thought random variation contributed to those gains. You can see the impact of this as you look at this simple scatter plot. Note that there were 11 practices that had their shared savings payments reduced as a result of this rule. The rule was actually permitted under our participation agreement, and I think we thought when we looked at the first year results that we were very fortunate to include this. So as I conclude my presentation, a few considerations on a multi-payer program, why we think it's important. And this is a term that practices really presented to us. They like the payer agnostic model. It allows for a consistent shared savings program. It allows to move towards consistent metrics. A large multi-payer program potentially can be linked with state improvement goals, and it can broaden participation in the market to smaller carriers by themselves who could launch a program. It also is important, I think, to talk about how how it can help sustain practice transformation. We think external practice support for transformation is critical. How that's funded is really a consideration I wish we had thought more about going forward. Care coordination and management, key, certainly the third rail of any advanced primary care initiative. And what we've learned, we have embedded care managers, but we think going forward a combination of provider-based and community-based support may work best. The role of electronic health technology cannot be understated and overstated, and we're fortunate here that we have very close linkage with our health information exchange, and we're working with them to support the diffusion of information through the HIE to practices. Practices have argued very strongly for standardized data feeds but have not yet made it happen. So our evolving efforts will focus as we move forward from the pilot to something broader is to continue to enhance primary care functions, to engage in coordination with the community and link providers in a more defined way, to begin to develop this concept of a community health workforce, which means establishing one in many Maryland communities as one does not exist, and then taking advantage of it and linking data systems. Where we are going then, and as Dr. Rosenthal noted, we are one of about 20 states that have received planning funds, is to take our multi-payer program up here, 330 practices, combine it with our largest single carrier program from Blue Cross Blue Shield, which involves about 2,500 providers. Our Cigna program, another program that will soon be approved, and bring it together through the planning process to increase the number of transformed practices, to more fully engage payers, to engage our communities in a more defined way, standardize metrics, and then to link all of these to the broader population goals that we in the state have defined in collaboration with the residents, providers and payers that are participating into this broadly integrated community medical home model going forward. I will stop here and pass this back to Dr. Rosenthal.
Great. Thanks, Ben. Now it's my pleasure to introduce Dr. Craig Jones, Executive Director of the Vermont Blueprint for Health. As a veteran innovator involved in Vermont's statewide transformation of healthcare delivery, Craig has agreed to provide his reflection and perspective on this topic. Craig?
Meredith, thank you very much, and I want to thank AHRQ and their team for the opportunity to be part of this and basically add on a little to the great information that Ben has provided us. We've had a lot of opportunity through the AHRQ Innovations Exchange to present the details of our program and the characteristics of it. So today I'm really mostly going to focus on how we've approached our payment models and what it's intended to achieve, and it offers a nice comparator to the Maryland experience. And I think the beauty of this is that we're beginning to get a set of examples across the country of the way these hybrid or composite payment models are beginning to emerge. So I'll go ahead and just give a quick outline of the program and then focus more on the payment models and some of the observations. Our blueprint model was really called on to develop a fairly comprehensive approach to delivery system reforms, and there was what I would consider visionary legislation or guiding legislation that was certainly looking at primary care but looking beyond, and as Ben alluded to almost community networks of support services. And so these are the elements that are in play right now in the Vermont model as it's expanding statewide. First off is of course, the patient-centered medical home, or what's called the advanced primary care practice here. We've expanded to 110 patient-centered medical homes in all health service areas of the state. In addition, we've put in place what we call community health teams, and this was an interesting construct. The intent here was how can you provide the multidisciplinary support that you really need, the team-based services you really need to patients and families in all these different types of primary care settings. Even if primary care works and transforms and improves, how are you going to get those teams available? And so in our case, the community health team was the answer that we played with and attempted to expand, and it seems to be working well. These are basically multidisciplinary teams. They're put in place by an administrative area in each health service area. They work embedded in the practices. They are effectively an asset or a resource as part of the practice, but they move between several practices. And so they're a fluid entity, if you will, a core resource. We almost view them as a utility to the medical home settings, and with time, they become a key and integral part of those patient-centered medical homes. Now, we have all our insurers supporting these core community health teams at a ratio of about 1 full-time equivalent for every 4,000 in the medical home setting. And that expands and is added to as the number of medical homes increases. And as in Ben's case and in Marilyn's case, our medical homes go through NCQA recognition, and with official recognition, they get the support of the community health teams. But in addition, we've seen several of the insurers expand on this and add additional care support resources that are more targeted toward more intensive groups. Medicaid has added on care coordinators to these teams to target their top high-risk population. And through our multi-payer advanced primary care demonstration, we not only have Medicare supporting the medical home payments and the community health team payments, they also are supporting what we call SASH teams. So these are support and services at home, and these are teams based in publicly subsidized housing around the state as a node, if you will, and they literally are providing in-home support to high-risk Medicare beneficiaries and forming teams. And this is really getting at the heart more of holistic health and human services, problems people have with limitations and activities and social and economic needs. And so the vision here was to try and put in place a advanced primary care transformation, but supported by community networks of teams that can really get toward a more holistic approach to health and human services. Now, this in our case is supported through insurer payment reforms. All our major insurers pay each of the medical homes based on their NCQA score, and I'll show a bit more about that in the next slide. And we consider that, I guess, an upfront or quality payment based on how they score. All the insurers are also sharing the costs of the community health teams and effectively putting in place a utility. There are no prior authorizations, co-pays, no barriers to patients. And so those two payments at this stage form the hybrid that is helping to roll out the Blueprint model. But I want to expand on another key aspect to this, and there's a lot of attention being paid to this in multi-state collaboratives we work with. The other supports that you really need to make a delivery system reform come alive and to really build these community networks or neighborhoods or however you want to view them. We have a tremendous amount of effort going into our health information infrastructure, a statewide health information exchange, but also a central clinical registry being fed from electronic medical record systems, hospital systems, and the network of community users, tobacco cessation counselors, health educators, SASH teams, contributing into the centralized clinical registry with the goal of producing what we call a community view or an integrated health record, a real complete health and human record so that these teams can deliver the best services possible. In addition, we have a intense investment and development of data systems for evaluation and reporting, as with Maryland, an all-payer claims database that we are using to, certainly study the impact of the program, produce practice profiles so practices can see how they're performing comparatively, and also use the output for predictive modeling and looking toward the next steps in health reform and payment reform. There's a number of other data systems that are going in place as well, the Central Clinical Registry being a good example as a growing resource. And I will just say the build-out technically of this is maybe one of the most complex aspects. Getting systems to exchange information or even contribute information that is normalized with good quality has turned out to be a really complicated task, but that's one we're working hard on. Another key aspect is, in addition to the medical homes and community health teams, a network statewide of what we call community self-management programs, things like healthier living workshops for patients with chronic disease, healthier living workshops for pain control, healthier living workshops for diabetes, tobacco cessation workshops, wellness recovery and action planning workshops. There's a growing network that we have of these statewide self-management programs. And in the end, I think it's all oriented toward a continuum of services extending from the medical home to the team-based support across communities, linkages with other services, and a strong emphasis on a move toward enhanced self-management ultimately. And lastly, what we call learning health system activities. And this is essential. Can you really drive transformation in the primary care practice or even across broader settings without the right supports? And the health information and evaluation systems are critical, but we believe there are other aspects to it, such as practice coaches or facilitators, the shared learning forums that they and others interact in. And so we have an array of activities that we put under that category, learning health system activities. And we're hoping that the data and the information generated out of the IT systems comes to play as actionable knowledge through these learning health system activities. So that's the bullet list, if you will, of the components that are expanding statewide now. As I said, we're at about 110 medical homes, about 420 or 30,000 people with access to those medical homes and community health teams, and about 550 primary care providers, including a good array of advanced nurse practitioners that are involved in the program. Let me switch over now to this slide and really focus on the way payment reforms or investments are being brought to play as we expand the blueprint. This is a simple way of displaying the payment streams right now. First of all, we have all our major insurers, including Medicare and Medicaid, paying the medical home a per person per month payment based on their NCQA score. This is on top of fee-for-service. Similar to Maryland, fee-for-service is still in place, and this in some sense can be viewed as a quality payment to help promote or drive patient-centered medical home transformation. It's not a large amount of money and frankly not enough, and we're re-examining that in terms of what primary care really needs. But interestingly, as a targeted payment stream, it's been effective in helping to engage primary care practices and drive transformation. It ranges from about $1.50 to $2.50 per person per month based on the NCQA score. The second is all insurers, as I mentioned, sharing the costs of the community health teams, effectively putting in place a utility and minimizing barriers for patients and families. And so these two payments effectively look like one for quality, the other to build a utility, and again, on top of fee-for-service. Now you'll notice the remaining arrows there all come from our blueprint budget, which is a state budget. We have an appropriation each year, and we view this as an investment in helping to build the infrastructure that is necessary for a real integrated health services system across the state. We have all the independent practices, organizations, hospitals, community providers that everyone else does. The question is, the challenge is, can we invest in a way that makes them operate with systemness even where there really isn't a single system? So the Blueprint grants support project management in each health service area. They're charged with bringing together the primary care providers, the hospital teams, the non-medical providers, mental health, area agencies on aging, social services, public health district office directors, the SASH teams, and on a regular basis having all these people meet in an integrated health services work group, plan what their community health team staffing will be, and continuously work to improve operations, coordinated services, and transitions. There's an incredible role for these project managers. They do an amazing job. In addition, our grants invest in practice facilitators in each area, and their job is several, but one is primarily at this point to help practices prepare to be scored as medical homes and really go through the transformation process, helping practices so they're not overwhelmed or certainly assisted with this difficult transformation effort. They'll stay in place and be focused on continuous ongoing improvement as practices are scored and become active medical homes. The Blueprint grants also support the self-management workshop network around the state, and this is a growing network that's taking on a critical role as a resource to communities and teams. Our budget also supports the Central Clinical Registry and data quality, and really data quality has become a key issue where we literally work site by site with core data dictionaries to improve the data capture and practice settings by health teams and make it so that it truly is normalized and can be brought into a single centralized registry. And this is where we're working to create the integrated health record view so teams can really operate across settings. And our contracts also support a range of evaluation, analytics, and reporting, and ultimately we hope moving toward predictive modeling as we link clinical data, claims data, other sources. And that's really one of our next steps we're going to be focusing on intensely. So this is from a payment or a financial point of view, a look at the two payment reforms that are driving this stage of transformation, and then the investments that the state is making in helping to develop the infrastructure. And frankly, this is viewed almost as building a foundation across Vermont, one in which next waves of payment reforms and financial reforms, such as ACOs, can build on top of, and with the hope that we optimize delivery systems and health service operations so that these higher level payment reforms can have a chance to be successful. So let me quickly talk about a couple considerations and comments. And you've heard, I think, this echoed throughout the discussion. Is higher payment enough? In our experience, we don't believe so. We think that there needs to be a steady investment in the infrastructure, some of the components I outlined for you, for real transformation. And particularly, even just within the practice settings, the need for practice facilitators to help prepare and undergo transformation. We have a University of Vermont team that scores every practice against the NCQA standards, so it's independent and objective. And those two resources alone, the facilitators and the scoring team, are an example of an infrastructure development that has really helped practices transform and begin to operate in this community network. So we believe that payment isn't enough, and in fact there's many of our practices that tell us the investment in the community health team, which doesn't go directly to them as money, is one of the things they value the most. To the question about to what degree can primary care organize holistic team services, they can, to a degree, and particularly within their walls, do some of that, but to really have multidisciplinary payment, it's critical that we get these, find a way to invest in these teams and get more holistic services. Let me go ahead and close out with this slide. And I think this is really the essence of today's discussion. We've heard about a couple blends of payment that are being taken to initially to drive transformation, but the question really is what payment or blend of payments will lead to the most effective and sustainable change. And we've heard about these upfront or capacity-like payments, quality payments, really investments. Ben presented a beautiful example of how shared savings is coming into play, but we're really at the front edge of this. And the question is, can we come to a balance that will achieve high quality and savings so that we don't fall into the dynamic of the 90s where savings became the sole major driver and gatekeeping was the theme of the day. And so with that, let me go ahead and finish up with just a slide that's showing a couple key advancements that will be coming into play here in Vermont in the next year, things we're excited about. I won't go into each of these. There's some new payment reforms coming in, and particularly I'll focus your attention on the fifth bullet point. What's expanding is a statewide model for addiction and co-occurring mental health disorders an investment in more community health team staff to help patients treated with Suboxone therapy and for mental health disorders in the medical home setting, and also specialized centers. So it's our first go at integrating specialized centers for the treatment of people with addiction disorders and mental health. New investments, all driven by infrastructure investment, and then we'll move toward payment based on outcomes and some important societal outcomes in this case, such as reductions in incarcerations or sustained employment. So these are just examples, and again, we hope this is the beginnings of a foundation for the next waves of payment reform and financial reform. And with that, I'm going to close it out and turn it back over to Meredith. And again, I want to thank AHRQ for the opportunity to be part of this.
Great. Thank you, Craig, and thank you both for your insightful presentations. I want to start the question and answer, and we have a lot of questions that have come in, but I wanted to start with a question for both of you to sort of zoom out from the really important work that both of your states have undertaken really on the ground in primary care. Can you talk, I guess first, Ben, a little bit about the receptiveness in Maryland of specialists and hospitals to these changes and how Maryland is planning to engage them? So Craig alluded to the sort of gatekeeper history that we've all been through, and wanting to think about this in a way that brings communities of providers together rather than drives them apart. So Ben?
Sure, thanks. So I didn't mention in my presentation that we have 9 ACOs in the state that have been designated by CMS, and unlike other states, because of the way that the ACOs were defined in the Accountable Care Act, Maryland hospitals cannot serve as ACOs. So these are all practice-led programs. In terms of engaging specialists, of course, I think that provides one opportunity limited to Medicare, although all of the payers are looking at that option. But I think generally the engagement of specialists is a big challenge under health care reform today. If you think of sort of the organizational change and the 3 principles, everyone wants to know is where are we going, what's in it for me, and how can I help? And I think we are working with specialists to help figure that out. I think the concept of the medical home binding specialists to these new models is extremely important. We are not there yet. I think the next iteration through this CMS planning grant will provide us some opportunities to look at better integration with specialists as well as integration with hospital services. Our hospital rate setting system provides us with some important advantages there to more fully engage hospitals.
Great, thanks. Craig, anything to add to that in terms of how Vermont is trying to bring the rest of the delivery system into this opportunity?
I think it's a similar way to how Ben described. There's ACOs forming and really working on the design of their standards and their measures, and I think that's a place in which linkage of interest, shared interests, if you will, between specialists and primary care are very likely to occur. And I think the hospitals are also looking at this as a way to help them move into a new business model, almost transform. The goal of these community networks and good primary care services is effectively to reduce unnecessary acute care. That's one of the key outcomes. So they're having to figure out how to evolve and to work in a new world, in a new environment. I think the ACO is offering them that opportunity to look at a steady shift in their business model. I would say that's one of the key things that hospitals will have to do.
Great. So, Judy, do we do one more, or?
No, I think we're coming close to the top of the hour, and I wanted to thank you all tremendously for your participation today, to our presenters with sharing this information, and to Meredith, and also to our audience. I want to draw your attention to the last slide. If you want to learn more about the Maryland program and the Vermont program, you can go to those. You can click onto those names on this slide, and it'll take you directly there, as well as there's a video series on the Vermont blueprint, which would be very helpful. If you have some additional comments and questions, you will see when you go to the different profiles for Maryland and for Vermont, there's a comment section, and you could submit your questions, your comments, and that will go directly to our innovators who were on this presentation today. Again, you could follow us on Twitter, and you could send us emails to info@innovations.arc.gov. And as always, we invite you to explore our website and to join us for future presentations. Again, thank you again to everyone.